Would you like me to introduce myself?
Please do.
Yeah. Hi, Rachel. Hi, everyone. Hi, everybody who's listening. My name is Rukkiya Ghani. I'm a speech and language therapist. I'm based in West Yorkshire, and I work at a hospital in Bradford in West Yorkshire. And Rachel's asked me to come along and have a bit of a chat, have a bit of a discussion about speech and language therapy, our profession, and what we're doing at the moment, and in light of COVID-19. So we've heard from Rachel and from Ashwin about, and they've covered some of the pathophysiology of COVID-19. So I won't go into that. I thought I would give a bit of a background introduction of, what does a speech and language therapist do? Some of you might be speech therapy students currently listening. Some of you might be wanting to think about speech therapy in the future, or just generally other HP students who are interested in what do speech therapists actually do? It's a common question. So speech and language therapists provide assessment, treatment, support, and care for children and adults who have difficulties with speech, with language, with voice, and swallowing difficulties. Now, it's such a vast profession, such a vast spectrum. We work with babies all the way up to the elderly. We work in so many different settings, so many different areas of healthcare and in the community. So we can be based in hospitals, healthcare centres, GP surgeries, schools, even in the judiciary system. And we even go out and see people in their homes. So those of us who work in the community, in community rehabilitation, we work in people's homes. And then for the elderly, in nursing homes and residential and care centres, etc. So trying to give you a picture of the spectrum of where we work and our profession and what we can range from, because some people, when they think of speech therapy, often they think we just work with children and we help people with their speech, and that's about it. But it's a lot more varied than that, a lot more specialized than that. So I'll talk a little bit more about where I work and my profession, so and in my sort of specialism, my area. So like I said, I work in a hospital. I'm hospital based. I work with adults only, not worked with children in my career. I've just focused on sort of the adult cohort, and I work with patients who have acquired neurological disorders of speech, language, and swallowing. So this is mainly based on the acute hospital wards. Again, there's a vast range within that. So within inpatient setting, you can have so many different areas of work, from ICU, from respiratory to the acute general medical, surgical wards, your general medical wards, and then there's stroke and neurology, and then we've also got ENT, voice, and then head and neck cancers. So again, within the hospital setting, it's a vast area. So that's what we do in the hospital. In terms of the spotlight on speech and language therapy in the context of COVID-19, now this was huge for us, for our small profession, a relatively small profession in a big AHP world. So as Rachel talks about the pathophysiology of COVID-19, and I won't go into that, but from what we do know, the symptoms include the patients who have cases of greater severity. They progress to acute respiratory distress syndrome, multi-organ failure, and or neurological sequelae such as stroke or Guillain-Barré syndrome. Then, if we're talking about the treatment of COVID-19, patients who've had impaired lung function secondary to oxygen deficiency and their acute respiratory distress, they'll often require oxygen therapy, and that includes nasal cannulas, high-flow nasal cannula, non-invasive mechanical ventilation, invasive mechanical ventilation as well. And then the impact of this on swallowing. So this is what I want to talk about. As we know that breathing and swallowing, they're closely interrelated and they're highly coordinated functions. So the impact of COVID-19 on swallowing is huge, because we can see that we know that the evidence shows us that non-invasive mechanical ventilation can affect oral and enteral feeding. The sedation that's used for this prolonged intubation increases that risk of pharyngeal dysfunction. Mechanical ventilation, such as prolonged intubation, that can also lead to laryngeal injury and dysphagia, which is the swallowing problems. Now, I won't go into it in too much detail and too much depth, of the medical side of it. But effectively, COVID-19 has impacted patients' ability to talk if they've had if they've been intubated, they've had tubes. If they've got this high flow nasal oxygen, it affects the ability to swallow safely. What we look out for is food and drink going into the lungs, and that can cause an aspirate pneumonia. It also has impacted the patient's ability to voice. So when we're talking about patients who are in intensive care and who have got breathing tubes or are needing high levels of oxygen, they're not able to communicate. It's a really difficult time at the minute when patients are in hospital, there's no visiting, they're scared, most of the staff are in full PPE and they're not able to communicate. And all the staff, all the MDT working with these patients are very much aware of this, and most of the time have our names written across our PPE, across our masks, visors, etc., and are really proactive in trying to communicate and keeping our patients safe and looking after them. But speech and language therapists, their role has been to come in, assess the swallowing, ensure that when patients are able to eat and drink orally, that whatever they are having is safe for them to eat and drink. We've been there to facilitate their communication, to help them to be able to communicate, and then also provide therapy and exercises and be able to rehabilitate any kind of issues with their voice as well and swallowing. So that's been the main role of speech and language therapists with COVID-19 in the hospital. Now, in terms of the wider impact on the wider workforce, Ashwin was talking a lot about redeployment. So now within the hospital, we had this massive change to the way we were working and things that we had to adapt to, as did everybody in the hospital in terms of PPE. During the first wave, we weren't sure, nobody quite knew what COVID-19 was about. It was a very, very new disease, and there were lots of things that we had to be able to adapt to in terms of PPE, finding out about COVID-19, the treatment. Everybody came together and tried to put this information together. And, you know, I really liked how Ashwin talked about not reinventing the wheel. We were all working together as AHPs. I remember at the time when we were putting together the information regarding aerosol generating procedures and what PPE should be used, and Rachel was at the forefront of this, and we all came together to get that information. My colleagues in the community and other areas, a lot of those would be redeployed, and I know some of my colleagues within the wider service were redeployed within the district nurses. Some came to help as healthcare assistants in critical care. Some of our colleagues who stopped their community outpatient clinics, they were redeployed into the acute setting to help where the most emergency and high priority work needed to happen. So everybody came together. That, you know, there were fears, there were anxieties, but we all worked together to get through that initial first wave, and adapting to the different way of working. And one of the other things that has really emerged from the pandemic is telehealth and different innovative ways of working where we're not able to do face-to-face as regularly as we used to before. My colleagues in the community who are not able to do that, they have now set up really robust and comprehensive telehealth programs where they're still able to provide assessment and treatment and care for our patients, but via this online telehealth method of reaching out. And that's had its challenges as well, but we've worked through them, and I think we've got to the stage where there's what we all like to say, the new normal now, and a new way of working. So that's where we're at the minute. I would say that for speech and language therapy students who are currently studying or working towards accreditation as a speech and language therapist, it's a really exciting time for our profession. I feel that COVID-19 has put a spotlight on what we do, because we're a small specialised profession that sometimes was, let's say, not bypassed, but not always in the spotlight. Not always, people weren't always aware of what we did, but COVID-19 has allowed us to really shine and see what we can do and how we can add value to the patient's journey, add to their care and treatment, and how important our work is. I mean, we talk about eating and drinking and communication, and these are really core and innate parts of being a human being, vital to quality of life. It's got to be at the forefront of what we do with patient care. And there's lots of innovative new ways of working, and it's just opened up a whole plethora of what we can do, what more we can do, what things that we might have been limited by in the past now means that there's so much more that we can do in terms of reaching out, networking, for people to be able to access our services. You know, that's been a huge difference for us at the minute. What else should I talk about? I mean, Rachel wanted me to talk a little bit more about, you know, the dimensions of the role, which I've covered. I've not really gone into paediatrics. Like I said, it's not my area, but I can, you know, point you in the right direction of some resources online. If you go to the Royal College website for speech and language therapists, there's lots of information there, and there's some fantastic speech and language therapists in the paediatric world of working who'd be able to give you some more insights. Rachel, are there any questions that you would like me to answer? Anything that's come up in the chat, or anything else you'd like me to cover?
Yes, can you hear me okay?
I can, yes. How wonderful.
Yes, there's a few questions actually.
Fab.
Can I ask what sort of interventions you do to support communication difficulties? So I suppose that might be coming from the PPE side, it might be coming from the ITU side, and then it might be coming from all the work you do in communication.
Yeah, I'm just trying to think that's vast, and which area. Okay, I'll kind of try and answer it in all those areas. So when patients are in, you know, when we're in PPE, so we're on the red COVID wards, as we call them, and say, for example, there's a patient who has a tracheostomy tube in situ that they use for breathing, and they want to be able to talk to their family. So there's a medical aspect of it where they're only able to achieve voicing if the cuff is deflated and they have a speaking valve in. If those things are in and they're able to communicate, we would facilitate speech that way. And if they're able, there's no actual deficit with their communication side of things, so it's just the motor side. So a lot of the time, those patients who have severe COVID-19 and are in ICU and respiratory wards, and they're needing to communicate, a lot of the facilitation is via sort of being able to help them use their phones, their iPads to FaceTime their families, those sorts of things. Then if we're talking about communication, how we would facilitate that for someone who has an impairment with their speech and language. So for example, a patient who might have suffered a stroke and be on a stroke unit, on a stroke ward, we would first assess the level of communication. Are they able to understand simple words, gestures, written language, spoken language, and find out what level they're at. So they might be able to understand single words, but not be able to understand full conversations. They might be able to speak some single words, but not be able to converse in full sentences. So we'd facilitate that communication by what we call a total communication approach. So that's speech, that is signing, that's using gesture, that's writing things down, it's using objects, using pictures. So a lot of the time it's about working out what level the patient's communication skills are at, how do we help them to express their needs and their wants, and you know, if they're wanting to try and converse, and then also a lot of the time helping their caregivers, the MDT around them, to give them strategies on how to help this person. So say, you know, if it's on a ward, with helping the nurse to understand that, okay, Mr. Smith, he's able to understand some, if you talk to him in simple words or use some short phrases and sentences, use some pictures, give some options, use a communication book. So a lot of it is strategies as well. So it helps the caregivers, the conversation partners, as it were, the skills to be able to communicate. So I think that covers that across the spectrum.
Thank you. Now, instrumental assessment. So have you noticed changes in your use of instrumental dysphagia assessment? And does your trust frequently have access to the use of VF and fees? I think this does change a little bit, doesn't it, where you work?
Yes, it absolutely does. So in terms of providing instrumental assessment, so as we know that, you know, according to the guidelines, instrumental assessment is a gold standard for your dysphagia. You know, the evidence is there. In terms of the trust where I work, we have access to videophroscopy regularly. which is consultant-led, consultant radiographer-led. Fees, we do have access to fees as well, which is a fibre optic endoscopic examination of the swallow, but that's in the head and neck team that we have. We don't have it regularly for our ICU, respiratory and medical. However, this is part of the service that I'm currently trying to develop, and then COVID-19 happened and everything halted. So yes, we do have the access. And the other part of the question was, sorry, Rich, can you repeat what the other half of the question was?
I think it's if we've seen any changes in instrumental assessment.
Changes, yeah. So in terms of COVID-19, obviously there's been a huge impact on what we've been doing with our videofroscopy and fees. When we're talking about COVID patients, it's difficult to get them into a VF when they are so acutely unwell. Then there's been the issues of the infection control, the downtime, the PPE, the fact that it's an AGP that we're carrying out, so that has its limitations as well. And very early on in the pandemic, we were advised by Royal College, and we followed those guidelines throughout, to only use instrumental. I mean, fees was just all endoscopy was stopped in the early days. So we weren't doing that at all. And videofroscopy had to be a risk assessment and whether it was absolutely necessary. So we were really, I mean, in the early weeks, we absolutely weren't doing any, but it was about, is this going to change the management for this patient? How effective is it going to be? Is it an absolute priority to be putting, patients in for this procedure where they have to go from the ward to the radiology suite, when we're looking at the downtime of the PPE and the viral load and the cross infection and the footfall and those sorts of things. So it was a risk assessment. But yeah, a short answer, yes, it definitely has affected our instrumental assessment service and what we've been providing to patients. But as we kind of started to come out of the first wave and things were stabilizing, we did increase that again, and then it stopped again. So we're kind of having to go with the flow as is most cases. Hope that answers it.
Yes. So can you give, or what exercises can you give for swallowing? Now,
controversial.
I mean, but the thing is, a lot of people think you can't give exercises for swallowing, but you can, can't you, with therapy?
So yes, absolutely. You can give exercises for swallowing. And again, this is an area that really interests me, dysphagia rehabilitation. However, we can only do, it's getting a little bit technical, we can only provide an exercise and rehabilitation regime for dysphagia, for swallowing, post-instrumental. You've got to be able to do your instrumental assessment, preferably your videofroscopy, where you can have a look at the anatomy and physiology. When you look at the physiology of the swallow, you see where the breakdown is, and then according to that, you can offer, right, we will do this exercise, we will do this rehab intervention, for example. There's various different types. There's the NMES, the neuromuscular electrical stimulation, that's used quite often. Then there are more functional approaches, which is, some of you might know of the McNeil dysphagia therapy plan. So, but all of those are dependent on your videofroscopy first. I wouldn't do a bedside assessment and then say to somebody, right, can you go away and do the Mendelssohn maneuver or this maneuver? It's because sometimes some exercises can be contraindicated. So I would say that would be your first port of call, and then you would follow accordingly.
Thank you. Now, have you seen any relationships with swallowing difficulties because of the prone positioning we use in the intensive care?
Yeah, so obviously that has a huge impact on swallowing. If you're thinking about when patients are proned and their heads are being turned, the tube positioning, that can have an impact. I've seen patients who post-proning, they have got sores around their mouths, the mouth internally is very sore, it can cause edema. Then if we're thinking about the ETT tube and the laryngeal trauma that can be caused because of that, and again, moving the head side to side during proning, yes, in a nutshell, there has been effects of that on the anatomy and physiology, which then has caused swallowing problems. Though I must say, in the majority of the patients who I have seen post-COVID with swallowing difficulties, which literature shows around 60% of those who were intubated would have swallowing problems, most of them, majority of them, have resolved over time. As those patients have got better and they've moved out to those acute stages, their swallowing has improved. There have been some instances where the trauma from the intubation has caused some long-term damage. There has been, I can certainly speak of one patient who we then saw in a follow-up clinic post COVID follow-up clinic and had a endoscopy, and it showed tracheal stenosis, so narrowing of the trachea, granulomas. We've noticed when we've done some endoscopy. So yes, there definitely has been an impact of the proning.
Thank you. And final question, and we do have a whole session on music therapy, but have you been able to use singing to help speech, which I think is a lovely question, or is that as an AGP, like an aerosol generating procedure?
I think it has, and I mean, pre-COVID, you know, we would use melodic intonation therapy in our communication work that we do, so it's definitely an aspect. However, when we're working in the acute setting, the majority of our work, if you're talking about not the stroke unit and the acute stroke and rehab, is generally dysphagia. I'd say around 80 to 90%, because it's prioritised. It's because it is, you know, a medical emergency. It's prioritised. Though I'm not saying that communication shouldn't be prioritised. Certainly in the pandemic, it was something that we weren't doing. No. But it has its place. It definitely has its advantages, and I'm hoping that, is it Melody who's going to be talking about? And that'll be her area, and she'll cover it more. But I mean, in a nutshell, yes, it would be used. It would be very effective. It would be very useful. But currently, it's not something that we're doing.
Yeah, so Priya will be doing the music Therapy, and Melody's doing the clinical psychology. But I'm sure they will overlap.
Absolutely.
Thank you so much. You are bang on time.
Perfect.
Comments on the chat are just so thankful of your insight.
I'm so glad. I was. I hope I've covered and talked about things clearly and, you know, comprehensively. The questions have been great. I wasn't expecting, you know, such insightful questions. So that's been fab, and I'd be happy to talk to people if they want to get in touch. I think my details are on the on your tweets anyway, so that's great. Thank you so much for having me.
Thank you, and thanks everyone for the questions. Keep them coming in. Thanks.
You. Bye everyone.
Bye, thank you. Now Ellie is with us. I'm just going to ask her to start her video. Now, I've seen the comments about repeating the pathophysiology and the physio talk due to the audio issues, so I will definitely be able to do that. Don't worry, I'll just work out whether we do it at the end or whether I just do a standalone recording, but more than happy to add it on if you guys are happy to stay and you want to listen to it after Melody's talk. So I'm delighted to introduce Ellie, who's a wonderful ODP, but I'm not going to steal her thunder. I'm going to let her tell us all about herself and what she does.
Thanks, Rachel. I don't know about wonderful ODP. So yes, hi everyone, I'm Ellie. Those that don't know what ODP stands for, who, if you're not an ODP online, is Operating Department Practitioner. So a phrase that has come out during the pandemic is we are the silent profession in the hospital. So majority of us work in operating theatres. Our backgrounds, there's a varying degrees of qualification. Currently it's diploma or degree. There's still a diploma running, although I believe it's being phased out. And primarily post-qualification, you will work in operating theatres for the patient's perioperative pathway. So through the anaesthetic phase, through the scrub phase, through the post-op recovery phase. But that's not only where we work. Many people work outside of theatres. They work as part of the resus team, more recently following COVID in intensive care, although pre-COVID, many people were advanced clinical practitioners and they worked in intensive care. As I know someone that works as part of a cardiac echo team. Within our trust, one of our matrons is an ODP, and a friend of mine at another trust is a matron for theatres, is an ODP. I currently have given up clinical and I'm a service manager within theatres. So as part of the qualification, you can work in a varying parts of the hospital. Following COVID, so for the first surge, I was clinical, and it highlighted actually that ODPs, a lot of us work in the anaesthetic and recovery phase, and actually COVID highlighted that we can work as part of the intensive care team. So I was part of the team that actually converted our theatres into intensive care and was on hand to assist the intensive care nurses in helping with having patients ventilated on anaesthetic machines, which wasn't ideal in the first surge. And thankfully, we haven't had to do that for the second, or is this the third? I'm going second surge. But we are still part of the team. So within our trust, we have what we call, it's called the CAST team, which is, I can't remember what it stands for, but essentially it's assisting all of intensive care for COVID. So we do part of the proning team, part of emergency intubations, any tube changes, transferring patients between intensive care, imaging, to theatres for tracheostomies. Also support if they, when we were overwhelmed with doing blood gases, just general patient care. All part of that team. ODPs were deployed into intensive care for that. Well, sorry, I'm having a bit of a blank. We do so much that it's my brain's just melted.
I think the thing is with ODPs, or operating department practitioners, and for any of you that's been in surgery or seen surgery, you think of someone assisting, supporting, and caring for the patient in those three phases of the surgery. So before, during, and after. But then all of the skills that ODPs have in relation to that, so airway management, the understanding of emergency procedures, the resuscitation, I think it's those transferable skills in like an acutely unwell environment that's I've never seen being used before, and I've worked in critical care for 20 years.
Yeah, I think unless you work in maybe resus or obstetrics, you probably, outside of theatres and intensive care to a degree, you wouldn't have heard of ODPs, because essentially we are there when there's a patient critically ill, either about to have a cardiac arrest or has had a cardiac arrest. I think COVID has actually opened up ODPs to a wider part of the hospital. So the trust I work in, we converted 2 wards to COVID CPAP wards, and the ODPs were going in to help on the CPAP wards. And a lot of people, I mean, in the first surge, a lot of nurses who came in to help in intensive care didn't know what ODPs did. In fact, I was told, you can't possibly help, you don't know what you're doing. And then with a bit of education, everyone was like, please come and help us. So yeah, our skills we are very much used to being the voice for the patient, because 9 times out of 10 our patients are anaesthetized and can't speak for themselves. So we are there able to foresee when things are starting to go wrong. We are there for critically unwell patients, and COVID has highlighted, most of these patients are critically unwell if they're in hospital, and if they suddenly go downhill, most of the time it's useful to have someone that has the airway skills around, because that is what is needed when you need to suddenly intubate a patient, or you get their airway back to functionally working, which COVID obviously is a problem with.
Yeah, and what do you think about, in terms of, for those people that are thinking about or have no idea what an ODP does, why would you kind of get involved? Like you said, it's one of the allied health professionals that, unless maybe you've had an operation as a child, or unless your parents have known someone, or like, where would you even find out about how to be an ODP?
So if you type into Google don't type in ODP, because it will take you to a weird ocean development project. Type in operating department practitioner. NHS Careers website has a great bit on it for ODPs. It's actually quite accurate. The College of ODPs, if you look them up, have a lot of information on how to be an ODP. What I will say is, if anyone wants to get in contact with me, feel free. I have been an ODP for a long time, and even when you're doing elective surgery, which can be, the same in, day out, you can do hernia after hernia. No 2 days are actually the same, because actually all the patients are different. I have been fortunate in my career to see many amazing operations, and have met many amazing people, and some people are just coming to have their toenails removed, but every day is different because every patient is different, so it makes every day different. You work as part of a large team within theatres, but also you can be as the anaesthetic team, just a tiny team, it's just you and the anaesthetist, and you could be out on a ward looking after a patient who's had a cardiac arrest, or in an anaesthetic room by yourself. You could be part of a 20-man scrub team for a huge operation, which is, could be filmed and being broadcast across the world, which does happen, or in recovery, where it's just you and your patient, and you're the first person that they see when they wake up post-operation, which, depending on the patient, might be a good thing, might not be a good thing, but you are that first contact with them. And every day is different. You don't ever have the same day. So yeah, if anyone is wondering what an ODP, how to find out information, contact me. There is a lot of information online for ODPs. But I would say, operating theatres are like a little secret bubble. No one's allowed in and no one's allowed out. But actually, there's quite a lot of information out there. You can find out what we do in theatres. And the one thing I'd say is we are the voice for the patient, because when you come in for an operation, I've had an operation, you're quite frightened. Even if you don't feel quite frightened, there is an element of stress. And as an ODP, you're there to take that stress away and hold on to that stress for the patient and let them just have their operation and get through that perioperative pathway, wherever it starts, whether it's in the operating theatres or the obstetric theatres, or even if you're, unwell and in resus, we're there to kind of take that stress away from you and be your voice.
So talk us through I think people might be wondering what it's like in the operating space. So you think about your surgeon. So if you think about a big surgery, like a cardiac surgery or something like that, or a big orthopedic surgery, and you think about, you have your surgeon and you have your anaesthetist at the top end, and then you might have your scrub nurses.
Yeah.
Who will typically, like you see on the TV, handle the instruments.
Yeah. So if you think of what you see on like Holby City, perhaps, which is it's actually not too bad representation. So you will have at the head end, typically will be your anaesthetist and ODP, could be an anaesthetic nurse. Obviously the operating table where your patient is usually surrounded in a circle with surgeons, and there will be someone who is scrubbed, one of a scrub nurse, or scrub ODPs. Everyone's called a scrub nurse. They're not called a scrub ODP. So you will be there handing the instruments over, but you're not just handing instruments over by rote. You're there to actually see what the surgeon is doing, predict what actually the surgeon needs, because sometimes they'll ask you for something, but it's not actually what they need. And also to keep an eye out for things going wrong. You are there to stop anything going wrong. I'm sure many people have heard about in the news where patients have had things left inside them by mistake, and as that scrub nurse, you're there to stop that happening and to say to the surgeon, actually, where is this swab, where is this instrument? Before we finish this operation, we need to account for everything, and also make sure that we are doing the right operation, because I'm sure people have heard of wrong operations being done. We are there to stop that happening. But also within theatre, it's not just you. There are several other members of the nursing stroke ODP team who are there to provide those second and third checks and say to the surgeons, no, most surgeons these days are quite nice. It's not like the old days of surgeons throwing things around operating theatres. That doesn't really happen anymore. It's not like that. It's not like it is on telly.
No, we were talking about this just yesterday, and it's like the misconception, particularly neuro and orthopedic surgeons, and back in the day used to be particularly, but I don't know if it's something about the stress, like operating on people's brain and spinal cords. But you're right, there's no excuse. But it was they got a really bad reputation, didn't they?
I think they've still got a bad reputation, which is a bit unfair, because actually 99% these days are quite nice. And actually, yeah, there is a stress in the operating theatre, but unsurprisingly these days we have some surgeons will listen to music whilst operating, because for some surgeons that is actually a stress relief. Some surgeons it's not, and so we'll ask for no noise in their theatre. But yeah, the old days of surgeons roaring at staff, thankfully is generally doesn't happen anymore. And actually there is a big human factors project that's been going around for many years, where encouraging all levels of staff to speak up should something be going wrong. And that is very much recognised, that it doesn't matter what level of staff you are there for the patient. You're all there for the patient. So that's what, you know, typically would be the image within the operating theatre. And then you move out to recovery, which is the best way to describe recovery is lots of sound, because there's lots of different patients, and then there's one-to-one care. So you do one-to-one care for patients post-op, and that's the best way. It's like a ward, but a bit busier and noisier.
So what's the best? I mean, it all sounds very exciting, doesn't it?
Yeah.
I mean, I do. For all the students out there, you have to get in the theatre when you're a student. I mean, don't take no for an answer, because when you get in there, find your ODP. I think that's the other message, isn't it? Because this is what we're trying to do, bring people together and give people a chance to experience other roles while they're a student.
Yeah, I mean, we have lots of students that come just for the day. We have lots of different students. We have lots of physios, paramedics, midwives, lots of nursing, obviously. But I always, if I've ever been to the ward and anyone wants to come to theatre, I just say, just contact me. And if you work in a trust and you're interested, contact someone in theatre. They'd be more than happy to show you around for a couple of hours or follow a patient pathway. It does open people's eyes when they come in, because it's completely different to what you think theatre's going to be like. Fabulous.
Now we have loads of questions in the chat, so we've got 5 minutes of Q&A. We will be finishing on time, everyone. So can there be a number of ODPs per operation depending on what's happening? Because I think someone put, is it usually one ODP per patient? Are there multiple ODPs with a single patient?
So you can have an entire theatre team made up of ODPs. So there'd be one for the anaesthetic phase, and then you'd have 3 or 4 in theatre who could all be ODPs. So you wouldn't necessarily have one ODP per patient. For the anaesthetic phase, it's generally 1, unless it's very complex, and then there might be 2 of you just to support each other. But you could go your entire perioperative airway pathway, and it could be all ODPs. It's unlikely because of the ratio of nurses to ODPs. It tends to be a mix of both, but it could be a whole ODP pathway.
Wow, I think I love that concept. Is there a shortage of ODPs?
Yes, there is.
Someone did put yes.
Yes, there is. Yes, there is. Sadly, not last year, the year before, 2 schools of ODP actually closed because it wasn't financially viable, which is, I mean, we already had a shortage of ODPs, and I think in a few years' time that will lead to a further shortage of ODPs. However, we have got apprenticeships coming up around the country. There's several universities that are accredited for apprenticeships, so that is another route into the ODP course, which is good.
This is a great question. Have you ever had a music therapist working in theatre with you?
No,
I've never heard of that either.
And that would be great in recovery.
Oh yeah, I mean, yeah, you might think in theatre, part of it's about reorientation, isn't it? Like, what's going on here? Where am I?
Yeah, it was. No, I never have actually, and I probably, anyone I ask that works in theatre probably hasn't.
Yeah, so I think the take home message is anyone can go into surgery as a student. It's just got to be it's got to be kind of appropriate, doesn't it? So part of it, I think, is experience in another profession. That's one route in to say, actually, I'm an allied health professional, or I know we've got physiologists, healthcare scientists, psychologists on the calls today, but that would be one route in, and it's just part of the patient journey, isn't it? And it's if you're going to be working in post recovery, so surgical wards, etc., it's always nice. And one of the lovely things, Ellie, is seeing the patient through, isn't it? So if you have that opportunity, if you are working on a ward, to say, actually, your patient's going down to theatre, say, ask for the patient consent, and you can. I've not known a patient ever say no.
No, and we have lots of and generally that's what happens, is we have lots of people asked to come with their patients, and I think it gives you a different insight to what your patient's been through.
Yeah, so dietitians can go in the theatre. In fact, I've known dietitians go in the theatre for sure. How long does it take to become an ODP?
So currently it's a 3 years. I did a diploma which took 2 years, but I think the diploma now is, some places it's still doing 2 years, some places doing it over 3 years, but the diploma, I believe, is being phased out, so it's a 3-year degree currently.
Thank you. Now we're just going to go through the phases again. So we'll have the anaesthetic phase, like the pre-op phase. We'll have the theatre stage. We'll have the post recovery phase. Yeah. Then we'll have ODPs working in, say, resuscitation teams and things, extended roles, and then obviously we'll have your roles as well in leadership, in management. Is there anything we've missed out?
There are some. Well, I guess it comes under resuscitation, but I do know some ODPs that work for like HEMS, so the ambulance service, the critical care ambulance service around the country. So that's completely pre-hospital care, which is completely different to in-hospital care. And I know a couple of ODPs who do event cover. So they're there for people who, not that we have events anytime soon, but they do, for big events, do event cover. So part of the critical care team for event cover.
Yeah, so the final comment, because we're bang on time, is just about some people just never have heard of ODPs or seen advertised and things. And I think that if this pandemic changes anything, Ellie, for me, this is it in terms of showcasing the roles and the unique skills. Because I think that's it for me. It's the unique skills that ODPs have that none of the other allied health professionals have, but also not really any of the workforce. There's lots of skills in anaesthetic nurses and things that transfer, but it's a very different role, isn't it? So
I think COVID has highlighted ODPs, and in fact on a national level, because one of I think an ODP in Wales took photographs of staff around intensive care and theatres, and it was on, I think it was in the Telegraph or Guardian, I can't remember, but it did put ODPs out there. But if anyone wants any information, I'm more than happy for people to contact me, and I can signpost good Twitter accounts who are good sources of information for ODPs.
Fabulous. And what subjects does one need to do to be an ODP? Well, I think it's just the normal, isn't it?
Normal
for all of us, science, maths, or English. But the NHS careers will be a good place for that.
It's probably pretty much the same as most allied health professionals.
Thanks so much, Ellie. Everyone, thanks so much for the chat. It's amazing. We are on track. We're coming back here at 10:30. So time for a quick break. Get up, stretch your legs. You can watch these, listen to these on the move, doing your tasks, whatever you want to do. You don't have to just sit. They are available to view after. I am going to edit this session, and we are going to repeat the first two from this morning later on. So thank you so much, Ellie.
Thank you, Rachel.
Take care.
Bye.
Bye. So thank you very much, everyone. I'm just holding so it doesn't cut out very early. Like I said, we will repeat the pathophysiology and the physiotherapy session after Melody's talk at the end.